Communication in palliative medicine. What is medical communication? Medical communication refers to the interaction between medical doctor, patients, families, peers, or society for the establishment of therapeutic alliance for that improves the quality of life of patients and their families. Communication is not related to just this verbal exchange. It consists of sometimes verbal, nonverbal, and paraverbal. Verbal communication consists of using the words and expression in order to make the link with the other person. Nonverbal communication includes eyes, contact, gesture, posture, face expression. Paraverbal communication includes communication in palliative medicine. What is medical communication? Medical communication refers to the interaction between medical doctor, patients, families, peers, or society for the establishment of therapeutic alliance for that improves the quality of life of patients and their families. Communication is not related to just this verbal exchange. It consists of sometimes verbal, nonverbal, and paraverbal. Verbal communication consists of using the words and expression in order to make the link with the other person. Nonverbal communication includes eyes, contact, gesture, posture, face expression. Paraverbal communication includes intonation or voice rate, voice quality, voice volume, voice rate, and so on and so forth. The medical communication has some goals. The first one is to ensure that the patient and families have the information they need to understand their experience as best they can, to ensure that patients and family are able to make informed decisions about their own care, to enable doctors to understand their patient's viewpoint, what do they understand, what might they not understand, what are their concerns, fears, hope. The more doctors knows, the more he can successfully address their needs. The subject important in palliative care is communicating bad news. Bad news is defined as the information which drastically and unpleasantly affects the human vision for the future. And in palliative care, examples of bad news could be information about incurable diagnosis or life-threatening illness, information about unfavorable prognosis, information about the occurrence of incurable diagnosis, starting opioid treatment, information about the possibility of loss of autonomy, information about necessity of mutilate intervention. Until now, very many physicians avoid to disclose bad news to their patients on the basis of the claim that it is risky for the state of for the health of the patient. However, nowadays this claim is proved false by very many studies. One of them, the study of Paliative, the title Truth May Hurt, but Deceit Hurt More, Communication in Palliative Care, says, desire to shelter patients from the reality of their situation usually create even greater difficulties for patients, their relatives and friends, and other members of the healthcare team. Though the motivation behind economy with truth is often well meant, a conspiracy of silence usually results in heightened state of fear, anxiety, and confusion, not of calm and equanimity. Consequently, there are a lot of advantages of breaking bad news. And also the studies mention that breaking bad news in direct and compassionate way can improve the patient's and the family ability to plan and cope, can encourage realistic goals and autonomy, can support the patient emotionally, can strengthen the physician and patient relationship, and foster collaboration among the patient, family, physician, and other professionals. The question arising here is how to break bad news in compassionate and sensitive manner. An appropriate approach is that of Canadian physician Robert Buckman, who proposed a strategy to announcing bad news in 6 stages. And this approach is titled spikes. Each literature designates a step in disclosing or in the session of disclosing bad news. The first step is setting, second, perception, third, invitation, fourth, knowledge, fifth, empathy, and the last stage, summary and strategy. In first step, the physician should prepare for the meeting of breaking bad news. In the second, to explore the perception of the patient concerning his medical condition. In the next step, to invite the patient to know all information about his or her medical condition. After that, to propose this information, to express empathy toward the emotion reaction, and the last time to make the future plan and strategies. We will discuss about each step, and the first one is getting started. Each step consists in some requirements, and concerning the requirements of the first step should be mentioned following. So any physician have to plan what will be discussed. It will be the information about diagnosis, about prognosis, about start of the opioid treatment, or any other information. Next requirement, it is confirmation of the medical facts of the case. The physician should ensure that all the needed information is available. Next requirement is necessity to create an environment conducive to effective communication. For instance, in case of pediatric patient, have staff available to be with the child while information is conveyed to the patients first, the parents first. A box of facial tissue should be handy, ensure privacy in an adequate setting, allot adequate time to the discussion. Do not slip this into a short interval between other critical tasks. Prevent interruption, arrange to hold telephone calls, and so on and so forth. And the last requirement is that the physician have to determine who else the patient would like to have present for the discussion. This might include family members or the decision maker or any key member of Paliative team, like nurse, social worker, chaplain, or somebody else. Step 2, in this step, the physician should explore What does the patient know about his or her condition? And in this step, the physician might use the following question. Do you understand about, what do you understand about your illness? What did other doctors tell you about your condition? When you first had these symptoms, what did you think it might be? What did Dr. A tell you when he sent you here in our services? With this information, the physician will ascertain if the patient and family will be able to comprehend the bad news. And with the answers to these questions, the physician will be able to understand how to proceed in the subsequent steps. Because if already the patient knows about the diagnosis, you should skip up until the last stage. If the patient doesn't know the information concerning his medical condition, you should proceed with the next step. And in this step, any physician should understand how much does the patient want to know about his medical condition. Each person has the right to voluntarily decline to receive any information and may designate someone else to communicate on his or her behalf. If the patient prefers not to receive critical information, you should establish to whom information should be given. For the reason of this task, you could use the following question. If this condition turned out to be something serious, do you want to know? Or another version. Some people really do not want to be told what is wrong with them, but would rather their families be told instead. What do you prefer? If the patient prefer the family to be informed, you should get the contact number of the family member delegated by the patient and to establish another meeting with this delegated person. If the patient prefers to be informed, you should proceed with subsequent step. Step 4 is a step of sharing the information, and the requirements of sharing information are as follows. Deliver the information in sensitive but straightforward manner. Avoid delivering all the information in a single steady monologue. Use simple language that is easy to understand. Avoid technical jargon. Pause frequently. Check for understanding. Use body language as a tool to facilitate the discussion. And do not minimize the severity of the situation, because well-intentioned efforts to soften the blow may lead to vagueness and confusion. You might choose to break that news by using language like, I'm afraid the news is not good. The biopsy showed that you have colon cancer. Unfortunately, there is no question about the test result. It's cancer. The report is back and it's not as we had hoped. It showed that there is a cancer in your colon. I'm afraid I had bad news. The bone marrow biopsy showed your daughter has leukemia. If you have a piece of good news related with established diagnosis, you should deliver it immediately after the bad news was broken. For instance, there is no doubt concerning the results of the test is cancer. But The good news is that the cancer is not spread in the body and we have the surgery option. Next step is responding to feelings. It is necessary to say that patients and families respond to bad news in a variety of ways, with tears, anger, sadness, anxiety, relief, denial, blame, or other strong emotion. And any physician should be prepared to support the family and patient through a broad range of these all reactions, to listen quietly and attentively, to acknowledge the emotion, to use nonverbal communication, for instance, consider touching the patient in appropriate and reassuring manner. Offer a drink of water, a cup of tea, or something else that might be soothing. Also, it is necessary to allow time for the patient and family to express all the immediate feelings related to the bad news. Don't rush them. Once the emotion is spent, most people will be able to move on. For being empathic and asking family and patient to describe their feeling, you can use the following expression. I imagine this is difficult news. I wish the news were different. Does this news frighten you? Tell me more about your feeling. What worries you most? What does this new news mean to you? You appear to be angry. Can you tell me what you are feeling? I will try to help you. Empathy is a facilitating factor for effective communication in palliative care, and it should be used at the level of all mentioned steps, but mostly it must be used in this step when already the information or bad news is delivered and the patient and the family need real emotional support. Empathy is defined as a phenomenon that involves the awareness of the patient's emotions and feelings, the manifestation of compassion, and the simultaneous management of own emotions. And the last step is the step of planning and follow-up. In this step, should be treated and discuss the current symptoms. Should we establish a plan for the next steps? This might include gathering additional information or planning for the test. Arrange for appropriate referrals. Should explain plan for additional treatment, discuss potential source of emotional and practical support like family, friends, social workers, spiritual counselor, peer support group, and so on and so forth. Reassure the patient and family that they are not being abandoned and that the physician will be actively engaged in an ongoing plan to help. Indicate how the patient and family can reach the physician to answer additional questions and establish a time for a follow-up appointment. Another subject which is very discussed in palliative setting is the subject of conspiracy of silence. And the conspiracy of silence is a medical staff and family members' secret agreement to hide from the patient a serious life-threatening illness. In palliative setting, the conspiracy of silence should be avoided because it break or violate the right of the patient to be an active participant of healthcare decision and to the right of the patient to be appropriately informed about his or her medical condition. Any physician or any member of palliative palliative team should be in the same time aware about the fact that there are some barriers of communication, and there are barriers due to the patients and families, like this mentioned here in this slide. Among them, a misunderstanding of illness, treatment option, and prognosis because of stress, misunderstanding of illness and option, treatment option and prognosis because of lack of support, lack of coping mechanisms, um, uh, lack of ability of concentration and understanding, and consequently of the decision making because of physical emotional depletion generated by the long and hard suffering of the patient, and so on and so forth. And there are also barriers due to healthcare providers. For instance, depth of physician-patient relationship might be a barrier in case if the physician develops a strong attachment toward their patients. Physical, emotional, and psychological stress and depletion of physician, insufficient knowledge related to understanding the emotional reaction of the patients, fears of emotional outbursts, fear of being blamed for the role of messenger of bad news, and so on and so forth. Also, there are factors that facilitate communication, and one of them is active listening. Active listening being the ability to extract relevant information as the patient is speaking, and it includes making eye contact with patient and approaching a neutral position, which shows that you are relaxed and not on the run. Another facilitating factors of communication are eliminating physical barriers between you, using open-ended questions, offering positive feedback, allowing periods of silence for the patient to organize their thoughts, using reiteration, using clarification, using the summary and checking the patient's opinion on the summary, inviting the patient to ask questions. Here you have the link of the session of breaking bad news, which might be useful to you to understand better the best steps of disclosing bad news, as well as being aware about some facilitating factors of good or efficient communication. Thank you for your attention. Hello, my name is Adriana Paladi, and I'm going to present to you some humanitarian aspects of palliative medicine. And the first one is the ethical aspects of palliative care. The first question is, what is the ethics applied to palliative care? And one very general aspect of this, let's say that the ethics applied to palliative care examines and prescribes moral standards which should facilitate best practice for those people who are receiving palliative care, those with an advanced chronic or terminal condition, in the aim of mutual benefit. What are the standards used in palliative care, or what are the moral standards used in palliative care? Even if in professional literature discuss a lot of standards, among the moral standards commonly used in palliative care are four principles. Principle of respect for person, principle of beneficence, and principle of non-harm, principle of justice. Any ethical principle consists of series of derived moral requirements and obligations, which says what must be done in relations to patients in palliative care and their families. The principle of respect for person consists of two basic requirements. The first one is respect for patient autonomy. This requirement implies people's wishes be respected and that they be helped to participate in decision about their treatment or care to the extent they are informed, willing, and able. And the second requirement is protection of patient with reduced autonomy, and this implies that in case the patient are not willing and able to help the patient representative to decide on behalf of patient protecting their best interest. Some obligations derive from these principles. These requirements are as follows. Health professionals should seek to discover the extent to which people are willing and able to be informed and to participate in healthcare decision making. Second, if the person is willing and able to give um, him or her accurate and timely information that enable them to understand the prognosis for their advanced chronic or terminal condition and the available care and treatment options. People wishes about their care options are thought and respected. People are encouraged to plan for their future needs and to appoint a representative if they so wish. A person's right to refuse additional treatments that they believe are having a negative impact upon their comfort and quality of life is recognized and respected. When people are unable to make healthcare decisions, they their previously expressed wishes, written in advance care directive, are identified and respected to the extent that they are still applicable and appropriate. An example of violation of moral requirements to respect the patient's autonomy is the case of a 40-year-old patient that accuses pain in the upper abdomen and back and is diagnosed with advanced pancreatic cancer. The patient informs the doctor that she wants to know the diagnosis, but the doctor tells her that the results of the test are not conclusive, but he thinks it is not anything serious. The decision of physician to hide the information about the diagnosis is a violation of the requirements to respect the patient autonomy or to respect the patient the right of self-determination, the patient right of being informed. The second principle is a principle of beneficence, and this principle requires promotion of the patient best interest. In palliative care, the patient best interest is improving the patient's comfort and quality of life. And there are two derived obligations from this principle. The first one is to understand what is in the patient's best interest, assessing systematically the person's values, beliefs, and overall being. I mean, the psychological, spiritual, physical, and social being, because only knowing these needs the physician will be able to fulfill them. And the second obligation is judging whether a specific care modality, treatment, option, or intervention may be beneficial, required, or overly burdensome for a particular person. And about this obligation, we will discuss a little bit more. Firstly, it is necessary to understand what type of treatment is beneficial one, and here you have some criteria of beneficial treatment. In other words, the treatment is beneficial if it is slow down the progress of chronic condition, sustain the person's life, reduce disability, and improve health, relieve the person distress or discomfort, and so on and so forth. Consequently, fetal treatment is a treatment that brings no one benefit from the listed measure or bring no benefit at all to the patient. Burdensome treatment is when the burden of that care or intervention for the person is disproportionate to the likely benefit. But there are many types of treatments which are qualified with higher burdensome in the palliative care, mostly in case of terminal patients. But more discussed is the cardiopulmonary resuscitation in event of heart arrest in terminal patient. This type of treatment is qualified as burdensome because even if it could extend a little bit the life of the patient, it could also extend the suffering and decrease the comfort of this patient. The third principle is the principle of non-harm, and this principle requires refraining from causing harm or risk of harm to others through certain action or lack thereof. The most important obligation derived from this principle is that the doctor have to know and apply the best standards of palliative care. Some examples of violating of the principle of non-harm is the case of nurse who knowingly fails to change a bandage schedule because it leads to the risk of harm. The second case is the case of physician who forgot that the patient does not want to receive certain type of information and discloses that information to the patient. And in this case, there is the risk of psychological harm. And finally, the principle of justice. This principle requires action for the benefit of the person to be weighed against the benefit of others. In short, justice in the delivery of healthcare involves respect for and fair benefit to all concerned. That means patients, families, and healthcare givers. Some derived obligations from this principle are as follows. Health professionals should avoid any kind of discrimination against people on account of their age, race, spiritual beliefs, or social situation. Healthcare resources should be used reasonably, wisely, and fairly. The needs of family and other carers are taken account when changes to a person management plan are being considered. People's preferences about where they are cared for are sought and implemented if this is practicable, safe, and fair to others. People with limited access to health care, I mean in rural and remote areas, should still have a reasonable access to essential specialist and palliative care expertise. All these principles are connected and related to each other, and the majority of the cases a physician should take into account all of them. However, sometimes in some situations, they could come in contradiction to each other. And in this situation, we are talking about a moral conflict. Moral conflict occurs when two moral principles or obligations are alleged by the case but are not achievable together. Moral conflict resolution consists in the careful weighing of competitive obligation and determining what of them has priority after careful examination of circumstances. An example of moral conflict could be the case of patient whose death is imminent, uh, and the patient is very close to death with regular respiration around 8 breaths per minute. The nurse needs to administer the pain medication, but to fear that giving it may hasten death. The nurse in this situation might feel conflicting with two obligations, two principles, the principle of beneficence and principle of non-harm. And in order to make the right decision, it is necessary to understand what is the best interest of this particular patient, and his or her best interest, of course, is to have a painless dying process. That's why administration of pain medication is the right decision. Thank you for your attention. Spiritual and psychosocial aspects of palliative medicine. The first question is, who provides spiritual and psychosocial assistance in palliative care? At the basic level, this type of assistance is ensured by all members of the healthcare staff. However, at the routine level, psychosocial and spiritual care is provided by psychologists, social worker, priest, spiritual counselor, and other providers. What is the basic objective of spiritual and psychosocial assistance in palliative care? The most important type of objective is creating of coping mechanisms. A coping mechanism is a way to deal with a difficult situation, is a strategy to avoid the negative impact on the comfort, is a strategy to remove or diminish an unpleasant emotion. A first step towards creating coping mechanisms is knowing the patient's perception, experiences, expectations, emotions, and needs at someone end of life. Or, in other words, it is important to know what do patients think, believe, and feel at the end of life. We will start with patient thoughts, or we'll start with the basic meanings of death. Actually, there are two meanings of death. The first one is religious meaning, and the second one is scientific meaning. From religious point of view, death is a process of transition towards another reality, is a process of transition toward another real, or transition towards eternity, because from religious perspective, the human has a soul, and the soul actually is immortal, and the death is actually the transition of the soul toward eternity. From scientific point of view, the death is a definitive end of human existence. The life is considered to be existence, the death is non-existence. After the death, nothing exists. Greek philosopher Epicure expressed this meaning in following sentences. When we are, death is not. When the death is, we are not. Humans also develop different kind of attitudes toward death. And two, the most important, is a perception of death as distance existent. And the second one is the perception of death as a close or nearby existence. These two types of attitudes were expressed relevantly by two philosophers. One of them is St. Augustine, and he mentioned death is something so strange, considered almost impossible despite any experience. It always comes as something unbelievable and unexpected. That means that majority of humans even know that they are mortal, um, consider that their own death is very far event, and they come. Usually, majority of humans are not prepared for that. And the second attitude is expressed by Martin Heidegger. He mentioned that any living thing, as soon as they become alive, is already beginning to die and vice versa. That means that death is nearby, or some humans believe that death is nearby because every day he is dying one cell, one relation, one dream, and so on and so forth. These type of perceptions depend on the type of human personality, but in the same time, it depends on the person or patient life experiences and, of course, of age. Also, in front of the death, human developed different kind of emotional reactions. And a very famous author, Elizabeth Kubler-Ross, in her book on death and dying, mentioned that actually majority of patients in front of death or loss feel the following emotions: denial, anger, bargaining, depression, and acceptance. And we will talk about all of them. What is denial? Denial is a normal reaction to rationalizing overwhelming emotions. It is defensive mechanism that buffer the immediate shock. When we dislike something, usually we try to deny or neglect it. People often think this isn't happening. This can be happening with me. Next reaction is anger. As anger actually is a reaction which appears after denial, and it's usually aimed at inanimate objects, complete strangers, healthcare givers, friends, or family. People say, why is it me? Why don't anyone help me? The people can be helped to overcome this stage by acknowledgement and acceptance of the emotions validity. Bargaining is determined by the need to regain the control over the proper life. People may make a deal with themselves, friends, God, in attempt to postpone the inevitable. Usually, people say, if I escape this time, I will never smoke. If I escape this time, I will never engage in dangerous behavior. If I escape this time, I will make medical checkup every 3 months, and so on and so forth. Depression comes with the full understanding of inevitable end. Patients become isolated, gripped by feelings of despair, sadness, and regret. This phase may be eased by simple clarification and reassurance. People may need a bit of helpful cooperation than a few kind words, but in the same time, attention to clinical depression. In order to assess the presence or absence of the clinical depression are used two screening questions. The first one is, in the last month, have you often felt depressed or hopeless? Second, in the past month, have you felt the lack of pleasure and interest from things that make you happy before? If at least one yes, you should apply the scale hospital anxiety depression in order to prove or improve your suspicion about clinical depression. Next and the last reaction is acceptance. This phase is marked by withdrawal, calm, and peacefulness. Reaching this stage is a gift not afforded to everyone, mentioned Elizabeth Kubler-Ross. Death may be sudden and unexpected, or people may never see beyond their anger or denial. Another author, Louise Susan, mentioned that the most common feelings in the front of death in palliative setting are loss, suffering, and hope. Loss is defined as the absence of a possession and occurs when something or someone is missing. Loss can refer to a person, relationship, thing, or situation. Patients reported having multiple losses throughout their illness trajectory. Some of these include the loss of work abilities, the loss of functional abilities, the loss of independence, the loss of health, etc. If left unmanaged, loss can cause a great deal of suffering. What is suffering? Eric Castle defines suffering as a state of severe distress which endangers the integrity of the person. Disintegrated personality leads to the loss of internal harmony and personal identity. Suffering can affect the body, mind, or spirit and can have different degree of intensity, from mild to intolerable, depending on the subjective perception of the individual. Following this definition, we can say that there are mental, biological, and spiritual suffering, and in what will follow, we'll discuss mostly spiritual suffering. Spiritual suffering is that which attacks the deep values of human existence. Also, it is called existential suffering. Spiritual suffering may occur in the absence of physical pain and may not disappear with the elimination of psychic symptoms, which means that it is not to be confused with somatic and mental suffering. Spiritual suffering becomes an inescapable evidence in the tendency of the patient to questioning of certain subjects regarding meanings, values, and relationship. For instance, about senses, patient asks, why do I suffer? About value, the patient asks, is there anything left of value or dignity when productivity and independence are lost? About relationship, who do I love? Who loves me? Am I a good parent? And so on and so forth. All these questions are derived from the needs. Questions about meanings come from the need to give or find meanings in the rest of one's life. Questions about values come from the need to be respected as a person, no matter what he can or cannot do, no matter how he looks like. Question about family, social life, comes from acute need for reconciliation. And finally, hope. Hope can be understood as a feeling of trust in the favorable resolution of a problem in the fulfillment of one's wants or needs. And hope can be an important factor for patients who are nearing the end of life because it is what gives people determination and will to go on. That's why the task of palliative team is to make a different type of intervention that would foster the hope. And among them are as follows: keeping symptoms well managed, encouraging involvement in positive experiences that transcend the patient current situation, fostering spiritual processing and finding meanings, promotion of reconciliation and connection with others, assisting patient in setting realistic goals, and of course, focusing the patient attention on the short-term future, not long-term future. All these interventions could be very helpful in fostering the hope, in increasing the quality of life of the patient and comfort at the end of their lives. And some words about social assistance. What is social assistance? It is a type of assistance that addresses all issues related to family and social environment. Social assistance consulting on internal problems of the family. Inform the family and patient about the formal social assistance provided by law, like pensions, welfare compensations. In the same time, social assistance assuring the material help for the family and for the patient. Thank you for your attention.